Case 1. A 65-year-old smoker presents with 4 weeks of hemoptysis and progressive dyspnea. So the primary radiographic finding in this first case isn't exactly subtle. There is complete whiteout of the right hemithorax with rightward deviation of the trachea, as well as the entire mediastinum. The left lung appears normal. What are some conditions that might cause this? Why would someone develop a complete lung collapse? In the setting of a smoker who is presenting with a subacute history of hemoptysis, the most likely explanation is an endobronchial lung cancer. Case 2. A 23-year-old woman recently returned from a trip to Africa, presents with 4 weeks of cough, intermittent fever, and weight loss. The first thing you probably noticed was the dense opacification of the right lower lung field on the PA film. Examining the lateral film, we see that the patient has an opacity in the inferior posterior part of the lung. Thus, this opacity is in the right lower lobe. This is a great example of the spine sign, in which there is an interruption in the normal progression to increasing lucency as one moves inferiorly down the spine on the lateral film. In addition, this opacity is well defined and dense enough to be referred to as a consolidation. On the PA film, if you examine this area more closely, I think you may be able to make out an air bronchogram. What is the etiology of this focal lung opacity? In this case, pneumonia is by far the most likely. The patient is too young for malignancy to be likely. She has no suggestion in the history or exam of a DVT or PE, and the remaining diagnoses are much less common. In this case, the consolidation is dense, appears to conform to the general shape of the right lower lobe, and there is no suggestion of cavitation. Therefore, this is a lobar pneumonia. In addition, although it is much more subtle, there appears to be the additional finding of some fullness just to the right of the trachea, which in the context of a probable pneumonia is most likely to be paratracheal lymphadenopathy. So in summary, the primary findings are a right lower lobe consolidation and possible right paratracheal lymphadenopathy. The impression, given the patient's history and exam, is that the patient has a right lower lobe lobar pneumonia. Case 3. A 38-year-old man with IV drug abuse presents to the ER with fever and a new heart murmur, suspected to be secondary to endocarditis, who developed progressive hypotension and respiratory distress over the first 12 hours after admission. Before talking about the findings, let's discuss the technical quality of the film, as it's obviously worse than the first two cases. First of all, the patient is rotated, not just around one axis, but around two. He's rotated with his right side lower than his left, which is generally a non-issue. However, if you look at how the spinous processes in the cervical spine relate to the clavicular heads, you can see how the spinous processes are much closer to the left clavicle, which means the left shoulder is rotated forward relative to the right. This can impact assessment of the cardiac and mediastinal silhouette. In addition, the vertebral bodies are not visible behind the heart, which suggests that there is suboptimal penetration or level of contrast. The final observation regarding the technical quality of the film is that the inferior portion of the thorax is cut off the bottom of the film altogether, limiting evaluation of the diaphragm. Now moving on to the actual findings, there are obvious diffuse bilateral patchy alveolar opacities with probable bilateral effusions. So what's causing those opacities? The etiologies of diffuse alveolar opacities can be divided into two categories. First, there is cardiogenic pulmonary edema, which is associated with an elevated pulmonary capillary wedge pressure, which is a surrogate for left atrial pressure. Any cause of CHF can lead to cardiogenic edema. The other category is predictably non-cardiogenic pulmonary edema, which has a normal wedge pressure. Diffuse non-cardiogenic edema is often placed into the spectrum between the clinical entities of acute lung injury and acute respiratory distress syndrome, or ARDS. The distinction between ALI and ARDS is simply based on how hypoxemic the patient is. There are many etiologies of non-cardiogenic edema, most notably severe sepsis, pneumonia, and aspiration pneumonitis. In the case of this X-ray, the cardiac size is normal, the regional distribution of opacities is patchy, we can see an air bronchogram right here, and there isn't any parabronchial cuffing. Regarding the last distinction, since there are probably pleural effusions but no obvious curly B lines, that gets split down the middle. Overall though, it should be clear that this is most likely non-cardiogenic pulmonary edema. Finally, there is the issue of the endotracheal tube, The tip of the tube should be placed about 5 centimeters away from the carina. Case 4. A 68-year-old man presented to the ER 2 days ago with dyspnea and weight loss, found to have a large left pleural effusion, which was drained via chest tube. He initially felt improved, but then abruptly developed severe shortness of breath and hypotension. So there's obviously a couple things going on here. Starting on the patient's left, we can see that where the left lung is supposed to be, it is completely devoid of lung markings, thus a large pneumothorax. This appears to be related to some technical problem with the chest tube, which is coiled up at the bottom of the film and appears to be extrathoracic. That is, it looks like it just fell out. As bad as a pneumothorax this large would be for the patient normally, his situation is even worse, as the rightward shift of the heart and mediastinal structures strongly suggests he has a tension pneumothorax. In a tension pneumothorax, air can continue to leak into the pleural space, but it can't get out. As the pressure builds, it shoves everything else out of the way and impairs cardiac filling to the point that cardiac output and thus blood pressure start to drop. This is a true emergency, in which the patient may have only minutes to have the lung decompressed before arresting. After that, the other major finding is almost like an afterthought, but the right lung is highly abnormal as well, containing innumerable tiny pulmonary nodules. There isn't really any radiographic clues as to the etiology, and even given the history of significant weight loss, this still could be anything from diffuse metastatic disease to miliary tuberculosis. In the case of this patient, a subsequent colonoscopy found a large adenocarcinoma, and PET scan found diffuse metastases throughout the body. Case 5. A 76-year-old woman presents with 1 week of progressive dyspnea and bilateral leg swelling. She reports her medical history is most notable for some type of heart valve surgery 30 years ago. The first thing you probably noticed is her cardiac silhouette looks large. The cardiothoracic ratio is equal to the maximum horizontal cardiac width divided by the maximum horizontal thoracic width as measured between the inner rib margins. Cardiomegaly is considered to be present if this ratio is greater than 50% on a PA film, which it clearly is in this case. While on the subject of heart size, a much more subtle finding has to do with the airways. In Lesson 5, I discussed how splaying of the carinal angle, that is the angle between the right and left mainstem bronchi, beyond 90 degrees is suggestive of left atrial enlargement. Next, there are some sternotomy wires, and right in the middle of the cardiac silhouette appears to be some form of foreign body, which looks awfully suspicious for an artificial heart valve. If we compare the silhouette of that valve against some examples of various types and designs, does it look similar to any of them? To me, it looks like a cage ball valve. And which valve has been replaced? Recall that if we take the cardiac silhouette and draw an imaginary line bisecting the spine, the valve that is closest to the middle is the aortic. The one that is down and to the patient's right is the tricuspid. The one down and to the patient's left is mitral, and up and to the left is pulmonic. In addition, comparing just the aortic and mitral valves, the aortic valve tends to be viewed more on the side from the PA view, while the mitral is seen more on face. Considering all of that leads us to conclude that it's the mitral valve that has been replaced. Finally, two last subtle findings are mild blunting of the right costophrenic angle, suggesting a very small effusion, and there is debatably some perihilar alveolar opacities. So putting this all together, the primary findings are cardiomegaly, possible left atrial enlargement, a caged ball mechanical mitral valve replacement, a small right pleural effusion, and mild bilateral perihilar alveolar opacities. Considering the patient is presenting with 1 week of dyspnea and bilateral leg edema, and has an elevated JVP on exam, the most likely explanation is a mild CHF exacerbation. It's unclear from the available information as to whether or not the MVR is playing a role. Although caged ball valves are extremely durable and have an essentially 0% rate of mechanical failure, they can develop blood clots and deformations of the ball, leading to mitral regurgitation.